The other major problem with this, as the study turned out, it was well designed, but as it turned out, was the number of patients who dropped out of either the cinacalcet or the placebo group and ended up taking commercial cinacalcet just prescribed by their doctors. So the result of that was that there was a much less clean distinction between the patients who had cinacalcet and the ones who didn't. What one would like to see in a study like this, ideally, is 1,900 patients who had cinacalcet, so 1,900 had cinacalcet, and another 1,900 who had no cinacalcet at all. That's what you would like. And that's what we do, of course, in practice, isn't it? We look at a patient and we say, are you going to have cinacalcet, or are you not going to have cinacalcet? Yay, no. Quite simple. Now, what actually happened here was an enormously high percentage of both groups dropped out, with the result that a lot of patients who were randomized to placebo ended up getting cinacalcet, some of them after only a few weeks. But they still counted as placebo patients because of the intention to treat and analysis. A lot of other patients who had dropped out altogether and taken nothing, if they were randomized to cinacalcet, they counted as if they had cinacalcet. But they may have had cinacalcet for one dose, in theory, but they still counted as cinacalcet. That's the way the intention to treat analyses work. And I think it does throw up for me, on a general point here, a real problem in terms of the way we do these big clinical studies, which are designed to satisfy the epidemiologists and the regulators like this, but actually often end up not answering the questions that doctors want answers to, and indeed patients want answers to. What I want to know, I've got a patient who wants to know, sitting in front of me, is, if I take cinacalcet, am I going to be any better or not? That's all I want to know, really, isn't it? I don't care. I'm not interested in what happens if I take cinacalcet for a week, then placebo for 2 years, and I'm going to be better or not. But that's the sort of thing that comes out of this. So it misses the point. Anyhow, that's a little hobby horse of mine, which I think is an important area. So in an attempt to get around some of these unforeseen problems with the way the study actually evolved, some slightly modified analyses were done. And these have been criticized by some, but I think many of us think that these analyses, sub-analyses, are quite justified. And one way of doing this is to do this thing called a lag censoring analysis. And that was, I won't go into the details, but that essentially is designed to try and reduce the impact of the patients who only took the cinacalcet for a very short period of time, and therefore didn't really count as proper cinacalcet-treated patients. And when you do that, you end up actually with a significant difference, a hazard ratio of 0.85, so it's not a massive difference, but it's highly significant, 0.003. If you correct for age between the two groups, you also end up with a significant difference. So I think it was bad luck that this study didn't deliver quite what it expected to. So this is the composite outcome here. And two other issues here, also on the lag censoring type analysis, that are of interest to me certainly, is how good is it at stopping you having to have a parathyroidectomy? The answer is very good indeed. Reduces the parathyroidectomy risk very substantially, has a ratio of 0.3. And time to fracture. Now, I'd been involved with a study a few years before this, which had appeared to show a 50% reduction in fracture rate in patients treated with cinacalcet versus placebo. That didn't come out on Evolve nearly as well, but it did come out here with a hazard ratio of 0.8, that was reasonably significant. So that's time to first fracture. So this was a really ambitious attempt that just didn't quite come off. But the more you look at the study and the more you drill down into it, the more you see that there are certain signals emerging from it, in my opinion. Right, let's talk a bit about vascular calcification and arterial stiffness now, in a mechanistic sense. These are old CT scans. These are electron beam CT scans. Now we use a standard spiral CT scanner these days. We're going to look at vascular calcification in a sensitive way. But this was from the time, this 2002, when the spiral CT scanners, I'm not even sure they existed then, but certainly they were not capable of looking at vascular calcification of the heart. So the technique used was electron beam CT scanning, and we've got pictures like this, which you've probably seen. And here is someone with coronary artery disease, not on dialysis, and you see a small amount of calcification. Here's a dialysis patient massive calcification there. And you know these data out on the left-hand side here. This is increasing age from left to right, so young on the left, older on the right, and looking at three groups of patients. One, the grey bars, patients who have no renal disease and no coronary artery disease. And then intermediate, the blue ones are patients who've got coronary artery disease, documented, but no renal disease. And then we have dialysis patients, purple. And you can see that in the coronary artery disease patients, there's an age-related increase, as you can expect, but it's nothing like as great or steep as happens in dialysis. And we, as nephrologists, are seeing vascular calcification on a scale that is way, way greater than the cardiologists in general see in their patients. Way, way greater. So it's worth bearing in mind that even at a youngish age, here you are 40 to 50, the prevalence of coronary artery calcification is equivalent to that of much older patients with coronary artery disease. So a lot of it about, but it's not the same. And as you know, coronary artery disease is essentially atherosclerosis. It's a disease of the intima at the bottom left here. It causes intimal proliferation, plaque, sometimes unstable plaque, sometimes therefore with acute occlusions resulting. But this is essentially an intimal disease causing occlusive lesions in arteries. Whereas what we have, largely in nephrology, is disease of the media, so the media is thicker here. There's not necessarily a very great increase in intimal disease at all in the patients we have. There's a modest increase, but it's not the dominant lesion. Calcification is in the media, not in the intima. And we get obstructive lesions from the intimal disease, and we get arterial stiffening as a result of calcification in the medial disease, which is the one we're dealing with. And it looks slightly different on X-rays. It's gross, and you can see it on plain X-ray. See on the left-hand side here, you can see it. And the point to note here is that it's quite focal. It's patchy, reflecting where the most severe intimal disease is. Whereas the medial disease is much smoother, looks like a pipe, which is what it is. So the morphology is somewhat different between the two types, and you can sometimes see that quite clearly. Now, it does make some difference as to outcome, what you have. So this is from quite early on. I'm afraid I haven't put the reference on yet, sorry about that. But looking at all-cause survival in ESRD patients, according to the presence or absence of arterial calcifications and what type they have, medial or intimal. And you can see that medial calcification is a lot worse than having no calcification, but the intimal calcification is even worse still. And that's probably because these people here, in addition to all the other problems with end-stage renal disease, these people have got occlusive lesions and they're getting gangrenous legs, strokes, myocardial infarctions, etc. So you do not want to have intimal disease and be a dialysis patient. Now, running very much in parallel with the arterial calcification is pulse rate velocity. And you get similar survival relationships here. You get survival on the vertical axis here. Now, pulse rate velocity, for those of you that don't spend much time thinking about it, you're better off having a low pulse rate velocity. Children have a low pulse rate velocity. The older we get, the higher our pulse rate velocity, and that reflects increasing stiffness of the arteries. This is part of the aging process. And the aging process in the arteries goes at an accelerated rate if you have CKD. That's the real problem. And you can see here we have a pulse rate velocity of less than 9 meters per second, here greater than 12 meters per second, and this makes a big, big difference to survival. Now, this can be measured non-invasively, relatively easily, but it involves a piece of kit, and in particular it involves a considerable degree of operator skill to get the measurements reproducible. And a surrogate for pulse rate velocity, though, that we all measure all the time, is arterial pulse pressure. And you all know, I'm sure, you're all coming across the phenomenon in clinics and things, the dialysis patient or the elderly patient with a transplant who's had dialysis, who has systolic hypertension and diastolic hypotension. blood pressure of 160 over 60, that sort of thing. We see that a lot. And that is a consequence of stiff arteries and a high pulse rate velocity, such that the systolic diastolic excursion is not damped out as it is by nice elastic arteries. So a child will have a narrow pulse pressure in these stiff artery renal patients, and indeed, if you look around the room, I'm probably going to have a wider pulse pressure than many people here. I can see who are younger than I am, and I'm sad to have to admit that as we get older, we're moving from there down this direction, which also means moving down the survival curve, which is not a very encouraging position to be in. However, keep your arteries soft and elastic. Now, what about evaluating it? So I said you can get a handle on it by measuring the pulse pressure. The utility of the pulse pressure is simply that we all do it all the time. So databases have that information on in enormous numbers of patients. As I say, it's not a necessary pulse pressure, but pulse rate velocity. What about calcification though? Now, I think it's unrealistic in Egypt, it's certainly unrealistic in the UK, to have a CT study done on everybody to see whether they've got vascular calcification or not. Certainly in my country, this is not going to happen, and it would be too expensive, not a big enough return. So the question is, can we get at this any other way? Well, we can get at it indirectly, as I said, by looking at the pulse pressure. That's a start. And the other way we can get at it indirectly is by just doing straightforward X-rays. We are looking at, where are we now? Sorry, I'm actually off the point here. I'll talk about a different slide. Let me just backtrack onto this slide. Beg your pardon. I think my next slide, or next, yeah, there we are. This slide. So here, this simply shows that, no, it's not. There we are. This is the correlation between electron beam CT scan to get a handle on vascular calcification and a plain abdominal X-ray, which is within reach. We can all do that quite easily. Now, an abdominal X-ray actually correlates reasonably well if you look here. Here's the coronary artery calcification score in 4 groups as judged by EBCT. And you can see that the X-ray scoring is not too bad. It's not as good, but it's not bad. And vascular calcification seen on plain X-rays, it has a very, very high specificity. So it's jolly good in that respect, but it's just the sensitivity is not very high. That's the problem with it. So you're going to miss quite a lot of them by relying just on plain X-rays. But when you see it, it's definitely there. So there's no argument about that. I'm going to see if I can go back to where I was before without losing the whole thing. Now, the next point I want to touch on is this strange inverse relationship between the amount of calcium we have in the skeleton of this dialysis patient and the amount of calcium we have elsewhere where it shouldn't be. And in general terms, there seems to be an inverse relationship, so that unless you have in your skeleton, the more you're likely to have elsewhere, including in the vasculature, and that's not where you want it for the reason we've been discussing. Here's some data on this. Again, goes back a bit, 1990, 1996. Looking at coronary artery calcification score here on the vertical axis here, and looking at vertical bone mineral density on the horizontal axis. And you can see that the higher your coronary, the more calcium in your coronary arteries, the lower your vertical BMD by and large. And that sort of relationship has been shown in many other studies. So I think it's a genuine relationship. And it's probably mainly to do with low turnover bone disease, I think that's the group in whom this is most likely to be happening. But that hasn't been specifically probed to the extent that it might be. There is some, though, evidence looking at bone turnover rates and vascular calcification. Now, these are patients, this is Gerald Longdon, who, as you know, has spent a long time studying these issues, a big body of work bearing his name. So these are patients who've had parathyroidectomies. And we're looking here at PTH and arterial calcification score. And you can see here that the arterial calcification score rises, tends to be highest in people with the lowest PTH. Looking at double-labeled surface area. Now, this is a measure of bone formation rate. This is tetracycline labeling, so this is a dynamic test on a bone biopsy. Again, you can see that there's not really a great deal going on there, in fact. But if we look over here at osteoblast surface, which is another measure of bone formation, we can see here again that the higher the arterial calcification score, the lower the bone formation rate. In general, I think the message here is that low bone turnover is more likely to be associated with high vascular calcification, which is why I think that probably that association I showed on the previous slide in largely reflects what's happening in the low turnover state. Another reason to believe that low bone turnover is not a good place to be. Pulse rate velocity and vascular calcification, so you're slightly out of order. You can see here, this is a group of patients looking at 3 tertiles here, pulse rate velocity in relation to coronary artery calcification. Pulse rate velocity rises, there's a big rise in coronary artery calcification. These two things go very closely together, very much in parallel. So stiff vessels are the ones that are most likely to be calcified. That one we've looked at. That one I go to the last one. Now, if we just consider the mechanisms of vascular calcification, why is it that these patients do this? And I'm not going to go into this in great length, but suffice to say that we know that, of course, calcium and phosphorus are in blood at concentrations that are precariously high given the solubility of the relevant source. And you could almost ask the question, not why do we calcify soft tissues, but why don't we calcify soft tissues the whole time? And the reason is that there's a balance between factors favouring calcification and factors that are inhibiting calcification. And that balance, if it gets out of kilter, is rather like looking at stone risk in the urine, for example, the metabolic composition of the urine. If that balance gets out of kilter, then we can end up with calcification. And it's based on the notion that the vascular smooth muscle cell over here on the left has a phenotype that is designed to function as a vascular smooth muscle. But it is capable of transdifferentiating into something more like an osteoblast and acquires a phenotype that is designed to operate in a calcifying environment. And it facilitates calcification and essentially is liable to make bone or something rather like it. And you look at this and you see what sort of things can move you from the left to the right. You want to stay there, you don't want to come over here. And you've got a list here of various things that can shift the axis from left to right. Note that phosphate is there as well, lipids there as well, various inflammatory mediators, leptin. And also calcitriol is here as well, although calcitriol, I would just simply say calcitriol at supraphysiological concentrations pushes you in this direction. And there's some in vitro studies showing that deficiency of calcitriol also moves you in this direction. And there's another U-shaped curve there in terms of optimal calcitriol concentration. What moves you the other way or helps protect you? Matrix guard protein, fetuin, osteopontin, there are various things here that are potentially useful in moving the other way. Clearly a major therapeutic target there if we can identify it properly. What about the hormones? Let's talk about vitamin D briefly, and then we'll talk about PTH and MGF. I showed this slide yesterday. The reason it's showing this is basically the vitamin D endocrine and non-endocrine system. We've got over on the left-hand side vitamin D supply. D3 from the skin, a bit of D3 in the diet, and D2 coming in only really if the food is supplemented artificially. Largely intake of D2 is minimal in a normal diet. And on the top we have the classic vitamin D endocrine system that we all learn about in medical school. So we generate 25-hydroxy in the liver, 125-dihydroxy in the kidney. The only other organ apart from the kidney that generates that in an amount sufficient to be a circulating hormone is the placenta. So the kidneys all the time, the placenta in pregnant women is the source of circulating 125, and that has effects on classical targets, gut, parathyroid gland, bone, for example. And so this is endocrinology. This is the kidney acting as an endocrine, quite simply. And the hormone is just that, a hormone. Now, note though that I put the figure of 5% there. That's because most of the synthesized 25-hydroxy does not end up being converted to the kidney to circulating 125. Most of it ends up going elsewhere. 80% plus ends up being converted mainly to 125, but in other tissues in the body. And the background to this is that most tissues, not just the kidney, have the enzyme that makes 125. It's the 1-alpha hydroxylase enzyme that converts 25-hydroxy-D to 125. So as we sit here, we're doing this in our muscles, our immune system, our hepatic cells, we're doing it in vascular cells. Most cells in the body make 125 in small amounts. So we're not making enough to spin out into the circulation and contribute greatly to the circulating 125 concentration, but they are potentially making enough to have a local action if there is a receptor locally that ligand can act on. And that's just the point. There is nearly all these tissues that can make their own 125, which, as I say, in most tissues in the body also express the vitamin D receptor. So they have the synthesis, the capability of making the hormone. I say hormone, it's actually, this is an autocrine or paracrine effect, it's not a hormone strictly. So they can make the ligand, vitamin D receptor, and they have the receptor as well, on the same cell. So this is an autocrine type response, and it's thought very likely that this type of mechanism is what underlies the effects of vitamin D, these so-called pleiotropic effects here on the immune system, heart, circulation, on tumorigenesis, and things like that. And what you could say about that essentially is that this really is local production of 125 for local use. Okay, so the machinery is all there to do that. And it begs the question, of course, that in our renal patients, the problem they've got is they haven't got kidneys, so they can't make the circulating hormone. They can't make enough of it. And so we come along and we give them 1-alpha, alpha calcification or something like that. So we essentially do hormone replacement therapy. What we do by giving alpha calcification is rather like treating hypothyroidism. Essentially, we're providing an efficient hormone. That's fine. And that deals with the issues to do with the gut, some of the issues to do with the parathyroidism, but on the classic hormonal target organs. But what it may not do is some of these things down to the bottom right of the problem, because they may require local synthesis to achieve the desired physiological response. So the point I'm raising here is that by treating these patients with calcitriol or alpha calcifiol, we may not be actually satisfying this bottom requirement as well. And the only way, and if I'm right, the only way to satisfy that is to give a native vitamin D back here, which can therefore feed into both pathways. And okay, you may say, well, the renal patient can't make 125 here, the kidney hasn't got a kidney that works, but we also know that renal patients are usually deficient in the precursor as well. Very, very common. It's pretty common in this world, isn't it? I mean, most of us have probably got lower hydroxy levels than an ideal, I dare say, for a variety of reasons. Renal patients, chronic disease, can be lower still. And what's the consequence of that? Well, again, built on association, not cause and effect association. You see this sort of relationship. This is from Tadani and Wolf in the US. Look at the left-hand side here, and we're looking at 3 groups of patients starting dialysis. These are incident dialysis patients. 3 groups: those who've got low 25-hydroxy levels, intermediate, and generous ones. And the red bars, the lower your 25-hydroxy level, the higher mortality risk is. And it's quite a big effect here too, you can see. So it's sort of 2.5 times increase in risk, which if genuine is very, very big indeed. What's interesting is that you don't see anything like such a big effect in association with 125-dihydroxy-D. So it's the precursor of the basic these data that seems to matter. The picture's not quite as clear as that then, for 2 reasons. One is that this study, also done by Tadani's group in Boston, was very interesting, and you may well be familiar with this one. Look at the top left here. This is looking at a very large number, I think about 30 or 40,000 dialysis patients from a huge American database. Looking at the survival based on whether the patients did or did not receive injected active vitamin D compounds. Now, injected active vitamin D compounds in America would mean intravenous calcium trial or intravenous paracalciton. They're pretty much the same in most respects, so we'll assume that no difference there. But those who've got active vitamin D showed about a 27% mortality reduction. So this is a historical cohort study. This is not a randomized prospective study at all. It does not prove cause and effect, but my goodness, it does show a big effect that may be there. What's extraordinary about this, in my view, is that if you then look at the different subsets based on the quintiles of phosphorus, or of calcium, or of PTH, you find that right the way across the range of phosphate, for example, there is a benefit of having received vitamin D as against having not received vitamin D. The received vitamin D is in black here. And it doesn't matter what your phosphate is, even if your phosphate is high in the highest quintile, then you still get the benefit, even though we would see that as being a relative contraindication to giving active vitamin D compounds. Likewise, calcium. We wouldn't normally recommend giving calcium trial to a patient who's already got calcium back at the top of normal or already abnormally high. But yet, even in that group, apparently, there is a survival benefit. Now, to me, that's all quite worrying, and I think that's very counterintuitive. I find that, but it's not entirely logical. And you think, well, what's the mechanism there? How does that possibly work? I don't know the answer, but what I do know is that this type of picture has emerged from a number of other studies that have been done. It applies to studies done in South America, Europe, using both injected and oral active vitamin D compounds. So it doesn't seem to make much difference what active vitamin D compound is used or how it's given. This sort of effect emerges. I've gone left ahead there. That sort of effect emerges. Now, what might this mean in terms of underlying mechanisms? Well, we said, of course, that anything that affects mortality rate in these patients is likely to do it by affecting